Thank you, Meryl, for the kind introduction. I want to first thank IMEDX and Dr. Epstein for inviting me to talk to you today about HPV. Definitely one of the very important topics in head and neck cancer in this day and age. It's very difficult to talk about head and neck cancer in 2013 and not really talk about HPV. So I'm going to review the impact that HPV has had on prognosis and treatment of head and neck cancer. I'm going to have a few slides in the beginning to talk about the epidemiology of this entity. This is a brief history of viral oncology. The link between cancer and viruses is very old. 1911 was the first description. For cervical cancer linked to HPV in the 80s, Dr. Hausen got the Nobel Prize for that. The association with HPV and oropharynx cancer was detected in the early 90s. Obviously, in 2006, we had the first HPV vaccine approved for cervical cancer prevention. This is the fascinating virus. It's a DNA virus. There's more than 200 types of HPV. You don't need to know all of them. The ones that really you should know about are the ones we call high-risk HPV types. Those are predominantly HPV 16 and 18. For head and neck cancer, oropharynx cancer, HPV 16 is the one that you're going to find most of the time. Now, the low-risk HPV types, such as HPV 6 and 11, are responsible for genital warts. So they cause benign conditions. So you have the high risk that cause cancer, low risk that cause genital warts or benign tumors. Now, HPV does cause cancer via its effect, via the E6 and E7 effect and the effect on the RB protein and P53. So in 2013, we have now strong evidence that linked HPV infection to oropharynx cancer. We know now that this entity is increasing in number. There are very few cancers in the US where the numbers are increasing. This is one of them. There is an increase in the number of oropharynx cancer that are linked to HPV. The other cancer that's increasing in incidence is the thyroid cancer, and we're going to hear about this later today. For thyroid cancer, I think there's more numbers because we look for it more often, not because there's a change in the epidemiology. But for this entity, for oropharynx cancer, there's clearly an increase in the number of patients with this entity for reasons that we don't necessarily understand right now. When we talk about HPV and head and neck cancer, remember we are talking about the oropharynx. HPV infects the oropharynx. This is where the tonsils and the tongue base are. This is not larynx cancer, it's not oral cavity cancer, it's not hypopharynx or nasopharynx. Even though in any of those sites you might find HPV infection, but the link there is not clear. For oropharynx, it's definite. And as I mentioned, HPV 16 is what you're going to find when you look for the HPV virus. So again, we're talking about tonsil, we're talking about tongue base. This is the oropharynx, this is where the infection occurs. Now, depending on which institution you work at, the proportion of patients with oropharynx cancer that have HPV 16 is going to vary. At our institutions in Boston, it's close to 75%. And this is a list of different institutions, the proportion of patients with oropharynx cancer that have HPV infection. So in the US, in Western Europe, in Canada, the vast majority of patients with oropharynx cancer now have HPV 16 infection. Let's talk about the epidemiology of this. So as you leave the room today, going forward, you should think of head and neck cancer in terms of these two columns here, because these are two different cancers. You have the HPV-related oropharynx cancer, and you have other, which is what Dr. Keys is going to address in his talk. So think of head and neck cancer as HPV-related and HPV-unrelated. The unrelated ones are the smoking and drinking-related cancers, and the HPV-related ones are the ones that are typically your 45-year-old male, non-smoker, non-drinker, has 2 kids at home, highly educated, who's going to do extremely well. Excellent prognosis for HPV positive. Contrast that with your 65, 70-year-old smoker, drinker, hypopharynx, larynx, oral cavity cancer patients who has a prognosis that's less superior. cure is in the 40 to 60%. So you have essentially a differential here in terms of prognosis between these two groups. And as you think of head and neck cancer, you have to think of HPV in terms of prognosis. So there's obviously HPV is a sexually transmitted virus. This is some of the list of sexual behaviors that are linked to HPV infection and oropharynx cancer. This paper by D'Souza in 2007 is a very important paper. I think you should all read. It kind of go over the epidemiology of this infection and the link to oropharynx cancer. The two behaviors that consistently correlate with oropharynx cancer: history of oral sex and multiple sexual partners defined as more than 6 lifetime sexual partners. Now, you don't need to have 6 lifetime sexual partners. This is a marker of contact, obviously. You can have 1 contact and acquire HPV. The other thing I would say also is keep in mind that most people who acquire HPV will never have a problem. So as we talk about this, and we talk about this a lot now, we have to be mindful that most people who acquire HPV are not going to have a problem. A minority will have cancer. And also the importance of this particular topic has to do with how you talk to spouses, how you talk to partners, what do you do with vaccination, because there's a vaccine for HPV, and I'm going to address some of those issues later. So when you look at a place like Sweden, for example, almost everybody with an oropharynx cancer has HPV infection. It's very high. So again, Western Europe, the Western world, there's a very strong association. Most people with oropharynx cancer will have HPV-16 infection. Numbers in the US also show a clear rise in the numbers of over the past 2 decades. We are seeing a rise, as I said in the beginning, of HPV-related oropharynx cancer. Those of you who follow the NCI reports, the NCI report this year of the state of cancer in the US highlights this problem. The NCI every year comes up with a yearly report about the state of cancer in the United States, all cancers. And this year they highlight HPV-related oropharynx cancer as an entity that is rising in numbers and a clear problem right now. How do you look for HPV? How do you know your patient is HPV positive? These are the methods you can use. In situ hybridization is the gold standard. P16 IHC is the one that most of us would use. Easy test, any pathology lab can do. You do those on the biopsy specimen. This is not a blood test. This is a stain that you do. These 3 tests, you do them on the biopsy. There's not a good serum test right now. There is one in the lab, but it's highly specialized. Very few people can do it. The way you check for HPV right now is you do one of these 3 tests. Most people will consider P16 IHC to be the easiest test to do and the one that gives you the most information you need, the quickest you need it. So it's a fast test to do. Again, any pathologist can do it. In situ hybridization gives you the type. It tells you this is HPV 16, 18, 31, 33. So it's a specific test, but it's not very sensitive. P16 immunohistochemistry is the one that at least most people would use, and also the one that the intergroup studies, RTOG and others, are using to determine HPV status. It's not very specific, but it's a sensitive test. And again, it's quick. You can get it within a day or 2. It gives you the information you need. PCR is very sensitive, but not very specific. Very few people do PCR. Now, why do you want to know your HPV? Why do you want to know if your patient is HPV positive? In my mind, it's the 3rd bullet here. You want to know that your patient is HPV positive because this information has prognostic information. It will allow you to determine whether your patient fits in a good prognosis group or not as good. It also, obviously, for us right now is a major stratification point in clinical trials. Clinical trials in head and neck cancer right now are geared toward HPV positive patients or HPV negative patients, so you need to know their HPV status. The second point, surveillance or screening. We don't have a good screen for HPV right now in terms of if you're a male and you want to know if you're HPV positive, not someone with cancer. If any one of you ask me, I want to know if I'm HPV positive, there is not a good test for that. A lot of people are doing on saliva test or other to try to find the HPV status. There are tests that can do that, but they're not commercially available. Obviously, for women, you can do a pap smear. That will give you a that will give you HPV information in the cervix, so that is available. The diagnosis and guiding of therapy, what I list here, metastasis of unknown primary tumors. So can you use HPV status to decide how you're going to treat a patient? This is controversial. The short answer is no. You should not use HPV status to guide your therapy. Right now, in 2013, you should essentially still treat all the patients the same way you would treat them, whether they're HPV positive or negative. Now, some physicians, and there's something maybe it will come up later in the discussions, might say, if I have a patient with an unknown primary squamous cell carcinoma, someone who walks into the clinic with a neck mass that's HPV positive, you don't know where the primary is. You did your workup, you removed your tonsils, you did a tonsillectomy, you did your PET scan, you can't find a primary. It's an unknown primary situation that's HPV positive in the neck. Some radiation oncologists will treat that patient as an oropharynx primary. That is controversial. That's not how we do it in Boston. I don't know how Merrill will do it in MD Anderson, but there is this entity of unknown primary where some physicians would use the HPV data to direct the radiation fields to the oropharynx, i.e. not treat the nasopharynx, for example, in someone who's HPV positive in the neck. That is, again, controversial. In my mind, the reason you check HPV right now is for prognostic information. So where does this information comes from? When we say that these patients do very well, where does this information come from? I'm going to show you really 3 examples. This is the TROG study. It was a study that was designed to ask a question, does tirapazamine, a hypoxic sensitizer, improve outcome in head and neck cancer? So this is chemo-RT versus chemo-RT with tirapazamine. Tirapazamine didn't do anything. This was a negative study. But that's not why I'm showing you this. I'm showing you this because an analysis of this trial based on the HPV status showed that if you're HPV positive, you did much better than if you're HPV negative, 94% versus 77%. So a couple of points. See how high the survival for those patients, 94%. Also, HPV negative patients are still cured, but not at the same rate and numbers. So HPV negative patients, even though they're not cured, but many of them still do very well. So that's the first example. This is stratification by P16 immunohistochemistry, same information. But this is really the study that will be, in a way, the gold standard to really answer that question. This is the RTOG study 0129. Now, again, this study was designed to answer a radiation question. It was not designed to answer a HPV question. The question that this study was asking is once-a-day radiation and twice-a-day radiation the same? So this is platinum radiation, 3 doses of platinum with standard radiation, or 2 doses of platinum with concomitant boost radiation, the MD Anderson regimen of radiation. This study showed that for that primary endpoint, there's no difference. If you gave once a day or twice a day, it was the same. I think the concomitant boost was a little bit inferior, but we're not here to talk about that today. The bottom line is, for that question, there was no difference. But this paper was published in the New England Journal of Medicine not to answer that question. It was published to answer the HPV question. That was the title of the paper. In that study, most patients had oropharynx primary. Most of them were tested for HPV. And again, 96% were HPV-16 positive, as you would expect. And these are the survival curves if you're HPV positive or HPV negative. So if you're HPV positive, you did much better than if you're HPV negative, 82% versus 57%. I would make one point here that is very important to remember. These patients here, is this working? Yeah. These patients here, not only they're HPV positive, they are non-smokers. So one thing we have not discussed yet, I'm going to discuss in a few minutes. For this best group, the good prognosis group, it's not enough to be HPV positive. You have to also be a non-smoker. If you're a smoker and HPV positive, your prognosis is not going to be as good as if you're HPV negative. So smoking still matters, even in the HPV positive patient population. Now, keep in mind, as I said in the beginning, many of these patients we see are non-smokers, non-drinkers, and they're HPV positive. Another example from ECOG that gave induction chemotherapy with carbotaxol followed by paclitaxel radiation. Again, this study showed that the HPV positive group did better than the HPV negative. I showed you here 3 studies, 3 examples of clinical trials showing that if you're HPV positive, you're going to belong to a group with a much better prognosis. And these are the numbers here, much lower rates of failure in the HPV positive group versus HPV negative. These are the local failures here, distant mets in the HPV positive and the HPV negative. Now, and this is a list of other studies that have showed that HPV positive group does better. I will point out to our study, the TAX324 study, the induction TPF. So even in our own induction trials, and the HPV positive group does better than the HPV negative group. So bottom line here, no matter how you treat these patients, and Meryl is going to discuss that, when you look at the HPV positive group, these patients do better. Now again, we spoke about HPV, but within that HPV group, are there other stratification factors that are important and relevant? And the one I'm going to really discuss is the smoking. Because as I said, smoking is still important for these patients. If they're smokers, then their prognosis is going to be not as good. So we mentioned the RTOG 0129 that I just showed you. And in that trial, they stratified smoking. That was statistical analysis, less than 20 pack here and more than 20 pack here. They considered the ones who were less than 20 pack here history to be non-smokers. And within those groups, if that best group, those 82% survival, those are your HPV positive non-smokers. The one that doesn't do as well are your HPV negative smokers, as you can see here. Clear difference between these two groups. So as I said, smoking still matters in these patients. This is another study by RTOG. This is a very old study, RTOG 9003, that compared 4 radiation schedules. Without chemotherapy, 4 radiation schedules, once a day, twice a day with a break, concomitant boost. And essentially the study showed that if you gave twice a day radiation, you did better. This was without chemotherapy, pre-chemotherapy era. So there was a further analysis of this trial done recently to really look at the smoking in these patients. And what they were able to show, the HPV positive, HPV negative. The HPV positive group is likely to be never smokers compared to this group. Very significant p-values here. Back here history, 29, 46, significant. So again, your smokers are likely to be your HPV negative group. And the same here for survival. Even in this very old study, this is more than 10 years ago published, 5-year survival for the P16 positive and P16 negative. So what I would say is tobacco pack here and P16 are independent predictor of overall survival and progression-free survival in patients treated with radiation therapy. So again, I showed you this in the beginning. This is another format. Think of head and neck cancer in terms of these two columns, HPV positive, HPV negative. This is Oropharynx. These are the young patients, non-smoker, non-drinkers. Rising incidence, excellent prognosis. Contrast that with the smokers and drinkers here. So NCCN recommendations about HPV. Do you have to check HPV status? Are you doing your patient a disservice by not checking HPV? At the Dana-Farber where I work, we check HPV on every patient with oropharynx cancer. We don't ask for it anymore. It's done automatically on all oropharynx as part of the standard of care. You don't have to look for larynx, hypopharynx, oral cavity, but the NCCN recommendations, and what we do is we check every patient with oropharynx cancer for HPV status, number one. Number two, it is not recommended that you use this information to guide your therapy, but you use that information to guide prognosis. Clinical trials. My last part here of my talk. So these patients do very well, but I'm still telling you, you should treat them the same way. So the questions being asked right now is, can we de-intensify therapy in these patients? Can we give them less chemotherapy? Can we give them less radiation or less chemoradiation? Or can we just operate on them and stop and maintain this high cure? Everything I'm saying here is investigational, is research. So part of a research protocol, you could think of de-intensifying therapy, giving less treatment, but that has to be part of a research protocol. This is a completed ECOG study that asked a de-intensification study question. So they gave chemotherapy first, And those who responded got less radiation, 54 gray instead of 72. This is a big de-intensification here. This is completed, but it's not presented or published or analyzed yet. This work is ongoing. But this is an example of de-intensification, and this you cannot do outside of a clinical trial. You cannot de-intensify therapy without a clinical trial. Another ongoing study by RTOG that's looking to enroll patients with HPV-positive good group, randomizing them to Cetuximab radiation or platinum radiation. So the question, the de-intensification here is omitting the cisplatin. So this is another form of de-intensification in patients with oropharynx HPV-positive disease. This is going to be a large study. It's ongoing and accruing very well from what I'm told. A surgical trial is being also planned by ECOG, again showing you examples of what's in pipeline and what's ongoing. In this trial, everyone will start with surgery. You'll operate first via robotic surgery or laser surgery, and then you have randomization between low risk and high risk. If you're low risk, you get nothing afterward. No radiation, no chemo. If you're high risk, you get everything. This study is about to start. This one, I think, will be led by Bob Ferris. There's another one who will be led by Chris Holsinger at Anderson for the HPV-negative group. So there'll be also surgical trials asking de-intensification questions, but again, until we have those, these remain investigationals. So my last slide. Majority of oropharynx cases are linked to HPV in the United States, Western Europe. This has a link to sexual practices. Excellent prognosis is seen in these patients. These patients will do very well. I think regardless of how you treat them, as long as you follow the standard treatments, sequential, concurrent, these patients will do very well. There's no evidence right now that one approach is better than the other in terms of chemotherapy. We still use platinum-based approach for these patients. We have not changed our treatment based on HPV status. And I would really reinforce that de-intensification is investigational and should not be used outside of a clinical trial. Thank you very much.